Thank you so much, and it's a pleasure to be back and to see all of you here today. I know many of you very well, having taken care of you, which means you're going to know my spiel already, and then many of you I don't. So I'm going to be talking to you about tools for treatment. I've combined the first three into one lecture, a lot easier. So what are the medical oncologist's tools for treatment? We have chemotherapy, immunotherapy, targeted therapy, combinations of the above, and in parentheses I've put clinical trials because other people are going to talk about those later today. So what is chemotherapy? Chemotherapy is cytotoxic. Chemotherapy kills cancer cells indiscriminately, usually by interfering with their DNA. Because it kills more indiscriminately, it also has side effects in other organs. Chemotherapy exploits the fact that cancer cells usually grow faster than normal cells. Here are some of the commonly used chemotherapy drugs for mesothelioma. And doctors always use the drug name, whereas patients are more familiar with the easier to pronounce brand name, so I've listed both. Pemetrexed, otherwise known as Alimta, and that was actually initially developed by one of the founders of the Mesothelioma Foundation, my mentor, Nicholas Vogelsang. Then there is cisplatin and carboplatin, gemcitabine, also known as Gemzar, and vinorelbine, also known as Navalbine. What is immunotherapy? So immunotherapy, they are drugs that target the immune system. Logical. So immune checkpoints such as PD-1, allow the cancer cells to be hidden from the immune system. And so your immune system says, hey, this is just Joe, right? This isn't anything abnormal. But the immune checkpoint inhibitors take off the brakes, and suddenly the body says, hey, cancer, you're not supposed to be there, and the body can then attack the tumor. So it's taken the brakes off of the immune system so that your own body can attack your cancer. So here are some of the immunotherapy drugs that are used for mesothelioma. I've listed those that are both in clinical trials as well as standard drugs, but the ones in bold are ones that are actually FDA approved for mesothelioma. And these include pembrolizumab, known as Keytruda, nivolumab, known as Opdivo, and ipilimumab, known as Yervoy. And so the first two target PD-1, and then IPI targets CTLA-4. So do immunotherapy drugs have fewer side effects than chemotherapy? Not really. They just have different side effects, which may be less predictable. So those of you who have taken chemotherapy, you kind of know what day you might have some nausea and what day you might have some constipation from the nausea meds and what day you're going to be tired or not feeling like eating, and then when you're going to be feeling like $1,000,000 again. But in immunotherapy, these immune responses can be activated anywhere in the body, and so the side effects are less predictable. You don't exactly know when you might have them. And so the most common side effects that we can see are tiredness, itching, usually goes away after a while, rash, or decreased thyroid activity. But basically, the immune system can get activated anywhere it feels like it and takes a left turn. Instead of targeting the tumor, it's targeting another organ. If it hits the lung, you get inflammation of the lung called pneumonitis. The adrenal gland, you'll get adrenal insufficiency. The eyes, you'll get uveitis. The mouth, mucositis. The joints, arthritis. The colon, you'll get diarrhea. The liver, you'll get hepatitis. Pick an organ, add itis to it, you've got inflammation. And people don't get all of them. They get one or two, but it's just a little bit less predictable than chemotherapy, and your doctor just needs to have the experience to monitor it closely so that before it starts to get bad, you know how to attack it. So what is histology? And Julie alluded to this, and why does it matter? So histology is what the cancer cells look like under the microscope. So you can see that purple guy, and that's an epithelioid, and the guy in pink is sarcomatoid. And even without the colors, I think you can kind of see that the patterns are different. And so I tell my patients that There are three main histologic subtypes: epithelial, sarcomatoid, and mixed or biphasic, but I use the analogy of chocolate, vanilla, and swirl because that sticks better with people, you know? And so why does it matter to know whether you're chocolate, vanilla, or swirl? Because chemotherapy and immunotherapy can work better in some histologic subtypes than others. So it's really important these days to know which one. And it has both predictive, it helps you know how the treatment's going to work, as well as prognostic. It tells you how well you're going to do. So it's really important to know that difference. What is a PD-L1 test, and does that matter in mesothelioma? So this is a test on a tumor sample that measures the amount of the immune marker PD-L1 on the cancer cells. PD-L1 testing can be used to find out if your cancer may benefit from immunotherapy, but it's different in meso than in other cancers. If your cancer cells have a high amount of PD-L1, you may benefit from immunotherapy. If your cancer cells have no or low PD-L1, you may still benefit from immunotherapy. So in some cancers, like lung cancer, we use that to direct whether we should give immunotherapy or not. In meso, it isn't quite as important. And that's partly because we have what we call heterogeneity in the expression. Some parts of the tumor have more of it than others. And so we really don't fully know if it matters or not, but we still report it. What is targeted therapy? So targeted therapy targets the biology of your cancer. And in some cancers, certain signaling pathways or molecular on-off switches that will promote cell growth are abnormally switched on or abnormally switched off. And so targeted therapy aims to turn off cell growth by blocking these signaling pathways. A lot of times we identify these by the test that Julie just mentioned, the next generation sequencing. So here are a few of the targeted therapy drugs that are used for mesothelioma. The most common target is what we call vascular endothelial growth factor. This targets the blood vessels that feed the tumors. And here the drugs are bevacizumab or Avastin and ramucirumab or Cyramza. I've listed here others that are used less commonly. One is ALK, and that's in young patients with peritoneal meso, and there are a number of drugs that can be used. And then there are many new targets, BAP1, NF2, MTAP, mesothelin, many others that other colleagues later today will be talking to you about in clinical trials, and I have several patients here who are on trials targeting various of these endpoints. Now, what do we mean by combination therapy? This is logical. Combination therapy combines two or more types of drug therapies: chemotherapy, immunotherapy, and targeted therapy. For example, chemotherapy and targeted therapy combinations would include pemetrexed, platinum, and bevacizumab, or gemcitabine and ramucirumab. Chemo plus immunotherapy, known with the easier term chemoimmunotherapy combinations, include pemetrexed, platinum, and pembrolizumab, while an immunotherapy and targeted therapy combination used in peritoneal meso is atezolizumab and bevacizumab. So how does the oncologist help you decide which drug treatment is best for you? So first, she looks at what drugs are most likely to work in your situation based on data from patients like you who were enrolled in clinical trials, as well as what other treatments you've already received and how well they worked. If the first treatment worked really well and it lasted a few years, you might go back to it. If the cancer grew on that first treatment, you're definitely going to try something that works very differently. Then we're looking at what key characteristics about your cancer might make one treatment more likely to help you, such as the histologic subtype of your tumor, the chocolate, vanilla, or swirl, as well as your overall health. Do you have other medical conditions that could be made worse with certain drugs, or that could affect how some drugs are processed in your body? So if you've got an autoimmune disease, you've got multiple sclerosis or myasthenia gravis, immunotherapy is probably going to make that worse. You don't want to take it. If your kidneys don't work very well, then you can't take a drug that gets excreted or processed by your kidneys, or it could become too toxic. Some older patients might not be able to handle certain types of drugs. If you've got lots of blood clots, you might not want to take a drug that causes blood clots, things like that. And then just your general overall health and what doctors call your performance status or level of activity. If you're spending all day in bed and on the couch, you're not going to be able to take something really, intense. Whereas if you're, playing tennis on the days when you're not in the clinic, then you're probably able to take a more aggressive treatment. And so it's all of these data that get put together in the discussion that your doctor will then have with you about what treatment the two of you should decide you should get. A few more definitions, and Julie already went through many of these. First line or front line is the first type of cancer drug that you receive. Maintenance is what you take to keep the cancer under control immediately after the initial therapy. Second line is the next type of treatment you receive when the cancer worsens. Neoadjuvant is what you get to shrink the tumor before surgery, and adjuvant is what you get after surgery to prevent the cancer from coming back. So these are the key milestones in drug therapy for mesothelioma, and I'd point you to that first column of the year. So that first study from 2003 that got pemetrexed approved, and that was one led by the MARF founder, Dr. Vogelsang. It then took 13 years from that trial to the next positive trial in mesothelioma. And then look how progress has really accelerated. 2 trials in 2020, 3 trials in 2021, and now 2023 and 2024. So really, over the last few years, progress has escalated, and we really are developing new treatments for this disease. And I'm going to talk about some, but not all of these. So let's talk first about first-line therapy options. You've never gotten treatment before, and you want to know what to do. And so these include pemetrexed and cisplatin, pemetrexed and carboplatin, pemetrexed and cisplatin plus the targeted drug bevacizumab, or pemetrexed and carboplatin plus the targeted drug bevacizumab. So that long-standing benchmark regimen, basically the only thing we had for almost 15 years, was pemetrexed and cisplatin. And this was based on a study done in less than 500 patients who either got a placebo, a dummy pill, a dummy IV with cisplatin, or pemetrexed and cisplatin. And for almost 2 decades, this was the only FDA approved for meso. Now, this is what we call a Kaplan-Meier curve. And if you see a difference between the 2 lines, it means that one thing is better than the other. So don't focus so much on the numbers, but just focus on that white space in between them. And this showed us that the combination therapy was better than one drug alone, and was important because it was the first time that we'd ever seen that something helped patients in mesothelioma. Now, cisplatin was what was used in the FDA study, but carboplatin is way much better tolerated. Cisplatin makes you feel like you got run over by a Mack truck. It can cause ringing in the ears, hearing loss, kidney damage, marked fatigue, nausea. And carboplatin is much better tolerated, is equivalent in activity, and in particular in older patients is more commonly used. Now, what about maintenance after pemetrexed and platinum? So there are 3 different options that can be offered. One shouldn't be. One is pemetrexed, one is gemcitabine, and one is bevacizumab. And so most patients will get 4 to 6 cycles or doses, so once every 3 weeks of pemetrexed and either carboplatin or cisplatin. And then their doctor usually tells them, okay, it's time to take a break. Let's go on to active observation, which is a really scary thing because you want to be doing something for your cancer. And so this was a study that looked at, should you just continue the slightly easier drug to take, the pemetrexed, or should you just go on observation? And this study showed that honestly, it doesn't help to take additional single drug pemetrexed. You're going to do just as well simply going on active observation so you can live your life and play with the grandchildren and do all of those things. And then when you need treatment again, you can get treatment again. So we don't use the maintenance pemetrexed for mesothelioma in general. This was a Dutch study that looked at the drug Gemzar, what's called switch maintenance. So let's switch to a different drug and see if that helps. So this didn't help people live longer. It may have helped keep the disease under control for a little longer, but this wasn't blinded. So the doctors and the patients kind of knew what they were getting. So we're not really sure if this helps or not. Not commonly done in the U.S., but it is done outside of the U.S. Now, the first study that was positive that showed improved results after the original Olympta trial was this trial, the MAPS trial from France. And here patients got pemetrexed, cisplatin, with or without the VEGF inhibitor bevacizumab. So this is the drug that targets the blood vessels that feed the tumors. And so either patients got the chemo, followed by observation, or they got the 3 drugs and then followed by the maintenance of the bevacizumab, the VEGF inhibitor. And here you can see again the difference between the lines, that the combination of the 3 drugs helped keep the disease controlled for longer, what we call an improvement in progression-free survival, as well as helping patients live longer. Now, this is actually because it wasn't designed in the U.S. This combination has never been FDA approved for meso, but insurance companies do pay for it. And one thing that we can see is that the patients who got the chemo alone actually did better than the patients on the original Vogelsang trial from 2003, even though they got the same treatment. And that's what we call a difference in historical controls, because other treatment aspects actually got better as well. So you can't look at a single unrandomized trial and say, well, patients here did better than patients from 10 years ago, because there are other things that occur. That's why we have to do randomization. Now, what about immunotherapy? So the standard approved first-line immunotherapy are the 2 drugs, ipilimumab and nivolumab, otherwise known as Opdivo and Yervoy, and they have these wonderful TV ads, lots of sunshine and joy and happiness. All right, so 4 years ago this month, the FDA approved the combination of nivolumab plus ipilimumab as first-line treatment for patients with unresectable pleural meso, the first new drug approval for meso in 17 years. And it's not like we weren't trying. We were doing lots and lots of trials in that interim, but this was really, incredibly exciting. All right. And so this was a trial called the Checkmate 743 trial, and it truly transformed mesothelioma treatment. And so here patients received either the nivolumab and ipilimumab or the pemetrexed with cis or carboplatin, and this was in 600 patients. And here we can see, again, that difference between those 2 curves, that white space between those 2 curves that showed that immunotherapy improved survival over chemotherapy. And remember, I talked about the chocolate, vanilla, and swirl. And so if you were epithelioid or vanilla, there was a bit of an improvement with immunotherapy, but not dramatic. If you had the chocolate or swirl, the non-epithelioid, you had this dramatic difference in survival. I illustrated to my patients, like, the epithelioids went from here to here, the non-epithelioids went from here to here. And so it's that difference that really dramatically affected patients for whom in the past we said nothing really works. And so that was incredibly exciting. It more than doubled survival in patients who otherwise had a really bad outlook. Now, that I mentioned before the PD-L1 expression, that immune marker, and here the difference was a little bit less. If you didn't have the immune marker, you probably did a little bit better with immunotherapy, but not dramatically. If you did better, but again, not super dramatically, but definitely better. And when we look at the results, again, don't focus so much on numbers here, but what we could see was that the epithelioid, the vanillas, wound up having basically equivalent outcomes to the chocolate and the swirls. And so we really were able to equalize outcomes among patients. What we could see then was that this combination was thought to be appropriate to become the new standard of care. What else did we learn? We learned that patients on immunotherapy felt better for longer than those treated with chemotherapy. And that's because patients on these trials filled out what was called a quality of life assessment or patient-reported outcomes. So those of you who have been on trials, you have to fill out all of those things saying, how are you feeling today? That's how we learn stuff about this. And so immunotherapy kept you feeling better for longer, even with some of its side effects. When we then looked a few years out after the trial, we saw again that patients with the epithelioid and non-epithelioid both still had similar disease control over time. And I think a better way to illustrate it is with this patient. And so these are x-rays or CT scans, and many of you have probably seen these before. Your feet are in my face, you're lying on the table, and you're being sliced like a roast beef. And here, this thing is the tumor. And so one thing you can see, black is air, and that is not good. So look at this patient from July to October. You can already begin to see a change. There's much more black there. And then look at him now. This is almost 10 years later. So when you get immunotherapy, if you have activated your immune system, it can be durable, it can last longer. This isn't every patient, but this guy's really enjoying his grandchildren that he's seen born over these years, and he's living his best life. So that is the best response we can get with immunotherapy. Now, immunotherapy, of course, as I mentioned before, can cause side effects because the immune system is more activated. And in some patients, they even have to stop immune therapy because of these side effects. But if the immune therapy activates your immune system to cause these side effects, it's also attacking your tumor. And so one thing that we've seen is that in patients who have to stop immunotherapy because of side effects, they actually do a bit better. And they do a bit better over a longer period of time because their cancer is still being attacked by the immunotherapy. So placing this trial in context, we saw that this combination really improves outcomes in many patients and is clearly a new standard of care. Now, I mentioned before in the chocolate, and swirl patients, in the sarcomatoid and mixed patients, this really revolutionized outcomes. But in the epithelioids, yes, there was a benefit, but maybe not as great. And so are there other options that might actually benefit those patients even more? And the answer is probably yes. And that is our first-line combination chemoimmunotherapy options. And so we have pembrolizumab, pemetrexed with cis or carboplatin, and atezolizumab, pemetrexed with carboplatin and bevacizumab. And so first there were several what we call phase 2 trials, so single-arm trials just testing the new drug in patients. And 3 out of 3 of them showed good response rates, higher than we would get with chemotherapy, and more durable survival than we might expect with chemotherapy alone. And these are what we call a spider and a waterfall plot. Down is good. That means tumor is shrinking. Down quickly on that spider plot tells you that responses are deep and durable. That waterfall plot, or the one where everything's going down like this, that one again shows you that tumors are shrinking. We saw substantial activity of chemo and immunotherapy in pleural meso. But this maybe again illustrates it even more. So this is a patient of mine from March to June. Just look for the black, and you see a lot less of it in March than you see in June. So chemoimmunotherapy or immunotherapy by itself can produce very rapid and dramatic responses. That patient couldn't walk across to the bathroom to brush his teeth in March. And now he's traveling all over the country and, living his best life. So these data led to a trial called the CCTG IND-227 trial. This was a study that looked at the pemetrexed and cisplatin versus pembrolizumab, pemetrexed and cisplatin. This was a Canadian, French, Italian study. And here we saw a difference in the two arms favoring the experimental arm. Nothing dramatic, because after patients who didn't get the immunotherapy completed their chemotherapy, some of them then crossed over and got immunotherapy, and that meant that the difference in the two outcomes was less. Here we can look at the histology, the epithelioid versus sarcomatoid, and here again the non-epithelioids had a greater difference. Here, exploratory outcomes, looking at the PD-L1 status. Again, perhaps here a benefit greater in those who were negative because you're adding chemotherapy in. But looking at this summary, one important thing that I've highlighted for you in dark blue is that chemoimmunotherapy can almost double the tumor response rate, or how much the tumor shrinks. So that in a patient where what you really want to do is to get significant tumor shrinkage because you want to take them to surgery, for example, then chemoimmunotherapy might be the better option. And so placing these data in context, when we first saw them presented, we said, this is better, but is it better enough to change the standard of care? Breaking news. About a month ago, the FDA approved pembrolizumab with pemetrexed and platinum-based chemotherapy as a new first-line treatment for pleural mesothelioma. And so now we have yet another active treatment option. That was pretty darn exciting. Then there was another study, another combination study called ETOP Beat Meso, and this was led by Sanjay Papat, who had up until recently been a very active member of the Meso Foundation. It's a little hard for him in the UK. And this study looked at the pemetrexed, carboplatin, and the bevacizumab, the drug that targets the blood vessels that feed the tumors, and added in plus or minus the atezolizumab, a drug targeting PD-L1, a very close cousin to the nivolumab or Opdivo. And so here we're looking at chemotherapy, targeted therapy, plus or minus immunotherapy. And here we could see, again, you got to squint a little bit, but you do see a difference between those arms. And while there didn't seem to be much of a difference at all with the chemotherapy in the epithelioid or vanillas, there was definitely a difference in the non-epithelioid patients. By the PD-L1, again, a difference here in those who were PD-L1 positive, the opposite of what we saw in the study I've just presented to you. And here we can see the progression-free survival. The patients had disease control for longer. Now, when we look here, this just summarizes the data that we can see. And placing this trial in context, the problem is that the data have been presented at a scientific conference, but have not yet been published. And we as scientists always want to analyze the data, parse it all out, and make sure we understand everything about it before we make a statement about whether this too is going to move in as a possible approved treatment regimen. So right now we don't know, but we can keep the fingers crossed. Now, how do we treat meso that has worsened on or come back after first-line therapy? And that used to be a much simpler question. When all you had was pemetrexed and carboplatin, you didn't have too many choices. But now that we have more first-line options, we also have more choices for second-line and beyond. So your choice of your second-line agent, it depends on a lot of variables. What you got before. Did you get chemotherapy? Did you get chemotherapy and targeted therapy? Did you get immunotherapy? Did you get chemo or an immunotherapy? It depends on whether you responded and how long you responded to your prior regimen as to whether you're going to treat with the same drugs or switch to something new. If the first treatment worked really well and kept your disease under control for 6 months or more, you might want to go back to the same thing. If your cancer grew right through it, you want to switch gears and try something your cancer's not going to be resistant to. And then there is also the histology. If you've got non-epithelioid versus epithelioid, you might not want to go straight for chemotherapy in a non-epithelioid, for example. So we know with pemetrexed-based chemotherapy that if you retreat with pemetrexed or pemetrexed and a platinum, if it worked for a while before, you can be retreated again, and even a third time if you need to. So if the disease was stable or responding for 6 months or more after you stopped it, it is a reasonable option to retreat. Of course, if there's a clinical trial or if there's other options, you might choose those, but that becomes one thing that you could do. Now, what about if you got immunotherapy? Can you then take pemetrexed platinum as a second line? We do it, but there aren't randomized trials to tell us how much better or not that is, but that's the other option that you haven't gotten. So another option is the combination of gemcitabine and the targeted drug ramucirumab. And this was an Italian trial that looked at gemcitabine with either a placebo, sugar water, or ramucirumab, and people were actually quite surprised. It kind of flew under the radar when we saw that both epithelioid and non-epithelioid patients gained benefit from this regimen. Now, it was a study that was designed in Italy, not with the FDA, and Cyramza or ramucirumab is not a cheap drug, and so insurance companies will not always approve it, but it is a reasonable option. Now, vinorelbine or navalbine is a drug that isn't used too often in the U.S. because it causes a decent amount of toxicity. But there's an oral version that is used in Europe. And so this was a study that looked at oral vinorelbine. And in the UK, they do a lot of studies with drug versus best supportive care. In the U.S., patients are not as eager to just go on, I'll just watch and wait. But this study demonstrated that indeed giving the oral vinorelbine could improve disease control, but it didn't really affect outcomes. So an option if you lived in the UK. This was a study that was also done in Europe that looked at whether patients got single drug immunotherapy or chemotherapy, which group of patients did better. And then if you got chemotherapy, you could cross over to immunotherapy. And here we saw that actually they offered pretty similar control, but if patients responded, they responded for longer if they got the immunotherapy, and they had a higher tumor response rate with the immunotherapy. So chemo can play a role, but you want to be very selective. This was another study from the UK that looked at immune therapy versus sugar water to see whether that after chemotherapy could provide disease control. And here we saw that indeed it did improve survival over not treating, and it did improve disease control. So a single agent immunotherapy after chemo is reasonable. The MAPS-2 trial looked at either single agent immunotherapy or double agent immunotherapy, and again showed that both offer disease control. It was a non-comparative study, so we don't know if one is better than the other, but it told us that that is a reasonable option. So to summarize the oncologist tools for treatment, over the past few years, I think you'll agree that we have finally begun to make real progress in systemic therapy for meso with many old and new approaches in our oncology toolkit. We've got chemotherapy, we've got immunotherapy, we've got chemoimmunotherapy. But how do we choose the best regimen for an individual patient? Well, some of these treatments are new enough that we don't have the full answer for every patient, and that's why we continue to do further studies. And of course, far more needs to be done. Research into the biology of the disease continues to uncover new targets, and many clinical trials of novel agents and approaches are ongoing. And with that, I thank you for your attention, and if there's time, I'm happy to answer questions.
Should I repeat? How How much can you assume that any trial you do for meso applies to all forms of meso, or do you have to have separate trials for pleural and peritoneal and others?
So that's a great question, because as you know, there are far more pleural patients around than there are peritoneal patients. Pleural and peritoneal are similar but are not biologically identical. In the absence of trials specifically for peritoneal meso, we tend to extrapolate and presume that they are similar. I mean, we have patients in the audience today who have tunica vaginalis meso, 20 new patients a year. There are not going to be randomized 500 patient trials for that disease either. And so to a certain degree, we have to extrapolate. But honestly, for peritoneal, there are now enough patients and enough momentum showing activity of agents that there actually are now trials, even a randomized trial that I presume someone is going to talk about later. And so as we learn more about it and refine more, I think that we'll realize that there are some differences. In the absence of data, we go along with pleural, but we need more data, absolutely.
Side effects from Avastin, is there anything that you make want to stop the drug because you're having what?
So Avastin or bevacizumab is what we call a VEGF inhibitor. It targets the blood vessels that feed the tumors, to be simplistic. And so patients can develop hypertension, high blood pressure. And if you need one drug or two drugs, that's fine. But if the blood pressure is still not going to be well controlled, that can increase the risk of stroke. And so that needs to be managed and monitored. It can cause something called protein in the urine, which isn't usually a problem at a certain level, but your doctor likely checks your urine each time or every other time just to be sure. It can increase the risk of blood clots, and if you have a blood clot, you're on a blood thinner, it's probably okay. Increase the risk of it can affect wound healing, and so patients with certain types of bowel obstructions, it would be contraindicated. But when patients are on bevacizumab maintenance, for the most part, it is much better tolerated. You don't have that fatigue that you get with the chemotherapy, and it's kind of reassuring to take something that is hopefully keeping that disease under control over time.